Bismillahirrahmanirrahim. Report of today is a verse from the Holy Quran. You alone we worship, you alone we ask for help. Assalamu alaikum. I'm Dr. Nabeela Umar, working as PGR in Department of Community Medicine. Today, I'm going to critically appraise a GBD article using the gathered checklist under the kind supervision of Dr. Saida Afzal. The topic of my article is Hepatitis B and C in Europe, an update from the Global Burden of Disease Study 2019. We are going to use the Gather checklist for this appraisal. This is the Gather checklist. First of all, we'll see that whether in the article there is identification of the global burden of the disease in the article. And in the article, either the abstract is structured with the headings of background, objectives, design, results, and conclusion. As we can see from the title, there is identification of the global burden of the disease in the title. This is the abstract of the article, in which we can see there are headings of background, methods, findings, interpretation, and also they have discussed the funding provided for this study. So the article shows that the abstract is structured with the mention of background, methods, result, and conclusion. Introduction of the article. Hepatitis B virus and hepatitis C virus can cause acute and chronic infections and are major causes of cirrhosis, liver cancer, liver transplantation, and liver-related death worldwide. Available interventions which are available include universal hepatitis B vaccine immunization programs, screening for hepatitis B virus and hepatitis C virus, and linkage to care, prevention of mother-to-child transmission, promotion of safe injection practices, stringent infection control programs, and antiviral treatments for people with hepatitis B and hepatitis C infection. The burden of hepatitis C and hepatitis B has been assessed in previous studies at the global and European levels. The global burden disease approach provides an opportunity to investigate the burdens associated with hepatitis B and C infections in Europe. Using the Global Burden Disease 2019 estimates, we aim to evaluate the incidence and prevalence of hepatitis B virus-related and hepatitis C-related diseases and their associated mortality and disability-adjusted life years in Europe from 2010 to 2019 to elucidate variations in the past decade when important treatment innovations have become available. According to the gathered checklist, number 1 will see define the indicators, population, and time periods from which estimates were made. According to the article, the indicators, population, and time periods were well defined. It is defined on the page number 3 of the article. Indicators include incidence, prevalence, mortality, and disability-adjusted life years. The population under study were of Central Europe, Eastern Europe, and Western Europe, and the study was conducted from 2010 to 2019, for which the estimates were made. List the funding sources for the work. Yes, the article have described that the study was supported by the Bill and Melinda Gates Foundation. Methods. This work is based on the data from Global Burden Disease 2019, which estimated disease burden from 369 diseases and injuries in 204 countries from 1990 to 2019. Several regression tools have been built for global burden disease and have been described previously, including the causes of death ensemble model and the Basal disease modeling meta-regression system. For all the diseases, the global burden disease approach estimates the associated burden in terms of incidence, prevalence, mortality, and disability-adjusted life years. All estimates computed in GBD were done 1,000 times at the draw level to account for uncertainty from input data, data adjustment, and model selection. Age standardization was done with the direct method, and population estimates for all combinations of age, group, sex, location, and year were taken from GBD demographic estimates. The study extracted the global burden disease estimates related to level 4 diseases associated with hepatitis B and hepatitis C, which includes acute hepatitis, cirrhosis, other chronic liver diseases, and liver cancer. The Global Burden Disease Study model acute hepatitis mortality, irrespective of virus type, using data from GBD cause of death database and cause of death assembled. Virus-specific deaths were taken when then scaled to fit within the parent envelope in causes of death correct. Cirrhosis mortality was modeled with the use of data in the cause of death database and proportion of cirrhosis cases attributed to alcohol, hepatitis B and C, non-alcoholic steatohepatitis, and other causes reported in serious case series studies. Total cirrhosis mortality was modeled with code M. Liver cancer mortality estimates were obtained from GBT cause of death database, which includes multiple sources of cancer mortality data and cancer registry data. GBT 2019 estimate hepatitis B seroprevalence and seroincidence with a multi-step approach. GBT also estimated the prevalence of hepatitis C viremia in a multi-step manner. The incidence from modeling hepatitis B seroprevalence was regarded as the incidence of chronic carriage. Incidence from modeling anti-hepatitis C antibody seroprevalence was regarded as the incidence of infection. For acute hepatitis B and acute hepatitis C, prevalence was estimated as the product of incidence of infection and an assumed duration of acute infection of 6 weeks. GBT modeled the prevalence of total cirrhosis and decompensated cirrhosis using hospital discharge claim data and disease modeling meta-regression system. The incidence of liver cancer was directly estimated from cancer mortality with use of estimated mortality to incidence ratio. The study report total numbers and age standardized rates per 1 lakh population for mortality, incidence, and disability adjusted life years, and age standardized prevalence per 1 lakh of hepatitis B related and C related disease in Europe from 2010 to 2019. Now, according to Gather checklist, for all the data inputs from multiple sources that are synthesized as part of the study, describe how the data was identified and how the data were assessed. The data were obtained from the Global Burden of Disease Study 2019, which synthesizes estimates from various sources, including registries, surveys, and vital registration data. However, the exact sources used and the identification process could have been elaborated further. Specify the inclusion and exclusion criteria. Identify all ad hoc exclusions. Not specifically mentioned in detail, the study uses comprehensive global burden disease methods, but ad hoc exclusions or data inclusions are not highlighted. Provide information on all including data sources and the main characteristics. For each data source used, report reference information on contact name, institution, population represented, data collection method, years of data collection, sex and age range, diagnostic criteria or measurement method, and sample size as relevant. The article mentions that the data sources are from the Global Burden of Disease 2019 study. However, it does not provide detailed references or contact information for the specific data sources used, nor does it list institutions responsible for contributing the data individually. The article describes the year of data collection from 2010 to 2019, but it does not give the details for gender and age ranges, and it does not include the sample size. Identify and describe any categories of input data that have potentially important biases, for example, based on characteristic listed in item 5. The article acknowledges potential data limitations due to gaps in vital registration system in some countries, which could introduce biases, and it has been described on the page number 13 of the article. For data inputs that contribute to the analysis but were not synthesized as part of the study, describe and give sources for any other data inputs. The study primarily used Global Burden Disease 2019 data, and no additional external data sources are mentioned. Provide all the data inputs in a file format from which data can be efficiently extracted, for example, spreadsheet rather than a PDF, including all relevant metadata listed for any data inputs that cannot be shared because of ethical or legal reasons, such as third-party ownership, provide a contact name, or the name of the institution that retains the right to the data. The article does not mention providing data inputs in an extractable format like a spreadsheet. Provide a conceptual view of the data analysis method. A diagram may be helpful. The article provides an overview of the data analysis method, including the causes of death ensemble model and a disease modeling meta-regression system. Code correct was used to ensure that the independently modeled single cause mortality estimates match the separately modeled all-cause mortality. Age standardization was done with the direct method, and population estimates for all combination of age group, sex, location, and year were taken from GVD demographic estimates. Provide a detailed description of all steps of the analysis, including mathematical formulae. This description should cover, as relevant, data cleaning, data pre-processing, data adjustment, and weighting of the data sources, and mathematical statistical models. A detailed description of the analytical methods, including statistical tools like disease modeling, meta-regression, and causes of death ensemble. Describe how candidate models were evaluated and how the final models were selected. The article lacks a detailed explanation of how candidate models were evaluated or how the final models were selected. Provide the results of an evaluation of model performance, if done, as well as the results of any relevant sensitivity analysis. There is no information on model performance evaluation or sensitivity analysis in the article. Describe the methods for calculating uncertainty of the estimates. State which sources of uncertainty were and were not accounted for in the uncertainty analysis. The article reports uncertainty intervals for the estimates, which shows that uncertainty was accounted for. State how analytic or how statistical source code used to generate estimates can be assessed. The article does not provide information on how to assess the statistical or analytical code used to generate the estimates. The result of the study. The age standardized incidence rate of the acute hepatitis B decreased, and the mortality rate due to acute hepatitis also decreased by 33.27% from 2010 to 90. Hepatitis B-related cirrhosis were characterized by a high prevalence, but the age-standardized prevalence rate and mortality rate of hepatitis B-related cirrhosis decreased from 2010 to 2019. Substantial reduction in disability-adjusted life years since 2010 were estimated for acute hepatitis B and hepatitis B virus-related cirrhosis, but not for disability-adjusted life years due to hepatitis B virus-related liver cancer. In 2019, there were an estimated 87,000 incident cases of acute hepatitis C. The age-standardized incident rate of acute hepatitis C decreased, and the age-standardized mortality rate decreased by 35.73%. The age-standardized prevalence rate decreased, and the age-standardized incident decreased by 5.87%, and the age-standardized mortality rate decreased by 11.11%. Age-standardized disability-adjusted life year rates due to acute hepatitis C and hepatitis C-related cirrhosis shows similar reductions to the daily counts between 2010 and 2019, but no significant changes observed for hepatitis C-related liver cancer. Deaths due to acute hepatitis B were highest in Eastern Europe and showed similar changes in Eastern Europe and Western Europe. In this study, the burden of hepatitis B and hepatitis C remained high in Europe and in 2019. Central and Eastern Europe had higher age-standardized mortality rates for hepatitis B-related cirrhosis and liver cancer than Western Europe. The age-standardized prevalence and mortality rates for hepatitis C-related cirrhosis were highest in Eastern Europe, while the prevalence and mortality rates of hepatitis C-related liver cancer were highest in Western Europe. The burden of cirrhosis decreased, and hepatitis B-related cirrhosis and acute hepatitis B shows the most substantial reductions. By contrast, the burden of hepatitis B virus-related liver cancer did not show any significant improvement to 2010 and 19. There are certain limitations of this study. The main limitation of global burden disease estimate is the low quality and availability of data in some countries. The variation in the availability of high-quality data across location influences the uncertainty associated with all the estimates and is reflected in our results by wide 95% uncertainty intervals for some estimates. Now, according to the gathered checklist, in the results and discussion, first they have mentioned provide the published estimates in a file format from which data can be efficiently extracted. The published estimates are not provided in extractable format such as a spreadsheet. Report a quantitative measure of the uncertainty of the estimate, for example, uncertainty intervals. The articles report uncertainty intervals for various estimates, which is mentioned on the page number 4 of the article. Interpret results in the light of existing evidence. If updating a previous set of estimates, describe the reasons for changes in estimates. The results are interpreted in the context of existing evidence, such as previous GBD studies. Discuss the limitation of the estimates, include a discussion of any modeling assumption or data limitations that affect interpretation of the estimates. The article discusses limitations related to data gaps, reliance on model estimates, and lack of vital registration system in some countries. This is the YouTube channel where this video will be uploaded. Thank you.
Thank you very much. Very nice presentation, Dr. Nabeela. I would like to ask you about the meta regression analysis that has been performed. What is your understanding about meta regression analysis? Dr. Nabeela, are you listening? Okay. So, what is your understanding about the meta regression analysis and the significance of the meta regression analysis?
Ma'am, I have a bit confusion about it. I'll study it and I'll then explain it in more detail.